Dr. Lin, if you want to go ahead and share your screen, and Dr. Pence, if you want to start your introduction.
Sure. So I'm Dr. Judith Pence, and I have the pleasure actually of introducing Dr. Lin. She's going to speak on Introduction to Psychedelics and Psychiatry, a brief trip through the history of psychedelics and the recent Psilocybin and MDMA research. Dr. Lin's a graduate from the residency program here, and that was in 2003. She then pursued additional training in functional medicine and became certified as a physician nutrition therapist or specialist, excuse me. She sold her practice in California in 2012 to join faculty here, and we've really been blessed with her presence here, I have to say. Since then, she's been focused on inpatient psychiatry and resident education, and is part of the teaching faculty for the integrative psychiatry elective. She helps support the nutritional psychiatry aspect of our training, and I've really appreciated her input. In 2019, she's ever learning and ever questing. She completed the certificate program in psychedelic assisted psychotherapy and research from the California Institute of Integral Studies. Thank you for joining us today, Dr. Lin.
Great. Well, thank you so much, Dr. Pence, for the introduction. And thank you all for coming to hear me talk about a topic that I'm very excited about and very excited to share, psychedelics and psychiatry. So these are my learning objectives, and I actually really have another sort of overarching objective here, and that is I hope to provide some evidence today to support psychedelic research being considered more mainstream and not just relegated to the fringe or to integrative psychiatry. So we'll start today with a little bit of history about psychedelics. So it's very likely that psychedelic plants and fungi have been used by indigenous peoples, early humans, well before recorded history. And we see evidence from early human artifacts which are depicting their use by indigenous people for medicinal and ritualistic practices. And just as an example here, this is a cave drawing from a cave in Algeria that dates back somewhere between 4000 and 1500 BC. And it depicts a shaman who's using hallucinogenic mushrooms, at least that's what it's believed to depict. Then if we fast forward all the way to the 1600s, in the so-called New World, Spanish conquistadors observed indigenous peoples utilizing psychedelic plants and fungi, and they viewed this as a form of devil worship. So they instituted harsh punishments, and this essentially just drove the use of these plants and fungi underground. So in the 1800s, Richard Spruce was a kind of a pioneer in the Western world in the study of hallucinogenic plants and fungi. And then came Richard Schultes, who was a professor of ethnobotany at Harvard, and he built upon Spruce's work. He spent many years in the Colombian Amazon, and he's credited with identifying the components of ayahuasca. So many years ensued, and then this is a picture of Albert Hofmann. So Albert Hofmann was a chemist. He worked for Sandoz Labs in Switzerland, and he synthesized LSD when he was working on developing a drug for apparently stimulating the circulation in some way. He was utilizing rye ergot. So he synthesized LSD, but he didn't know anything about the psychedelic properties until 1943, when, at least as the story goes, he accidentally licked his finger in the lab, and he felt so strange that he decided he needed to go home. Well, his mode of transportation is a bicycle. So he rode his bicycle home and had a very incredible experience, and he wrote about this experience. And then from that day forward, that day, which was April 19th, was known as Bicycle Day. So in 1957, there was a Wall Street banker whose name was R. Gordon Wasson. And he had a hobby of studying mushrooms. And he read about Schulte's work about the hallucinogenic fungi. So he went down to Oaxaca, where he participated in a psilocybin ceremony with a Mexican shaman named Maria Sabina. He then wrote about this experience in an article that was published in Life magazine. So this article really increased public awareness of hallucinogens. So in the late 50s and early 60s, there were a few psychiatrists in the US who began giving very small doses of LSD to their patients as an adjunct to psychotherapy. The thinking was that it helped to enhance access to unconscious material, and it seemed to reduce people's defense mechanisms. So there were several people who participated in this therapy, but Cary Grant was really probably the most famous proponent of this type of therapy, which is called psycholytic therapy. He was interviewed in the Good Housekeeping magazine, and so this further increased public awareness about psychedelic agents, but it also introduced to the public the notion of psychedelics as potential medicines. Around this time in Canada, a psychiatrist named Humphrey Osmond was using LSD-assisted psychotherapy to treat people with severe alcoholism. And he is the one that actually is credited with coining the term psychedelic, which means mind manifesting. So throughout the 50s and up and through the early 70s, psychedelic assisted, well, usually it was LSD assisted therapy, continued to show benefit for severe and often refractory alcohol use disorder. And this was being studied in Europe and in the US. 1963, there was a Walter Pahnke, who was a psychiatrist as well as a minister, and he conducted a fairly famous study called the Good Friday experiment, in which he had a group of theology students, and he gave some psilocybin, and then they went and wrote about their experiences. Later, this psychiatrist Pahnke studied LSD-assisted psychotherapy with people who are dying of cancer. And he wrote about the significant improvements in depression, in their level of pain, and in their fear of death that these patients experienced after their after their LSD experience. Stan Grof, who was a Czech psychoanalytically trained psychiatrist, came over and joined the faculty at Johns Hopkins. And this was in the early 60s through 73. He did many open label trials utilizing different psychedelics, usually LSD and sometimes DMT, with hundreds of terminal cancer patients who were suffering greatly from existential distress. And he documented very dramatic improvements in their levels of depression, their fear of dying, their anxiety, their quality of life, and in the level of pain that they were experiencing. So Stan Grof went on to become a really prolific author, speaker, teacher, known for he's had many quotations that he's known for. One that I included here, I thought I would share with you. He said, "Psychedelics are to the study of the mind what the telescope is for astronomy and the microscope is for biology." So now we are in the early 60s at Harvard, and here are two young psychology professors, Timothy Leary and Richard Alpert, and they are eager to study psychedelic agents. So they did receive permission from their department to experiment, but they were told they could only give these psychedelic agents to graduate students. They were not allowed to give them to undergrads. And just as a side note, these drugs were not illegal at this time. Now, as the story goes, Andrew Weil, who is our famous guru of integrative medicine now, at the time he was a freshman at Harvard, And he was very interested in being a participant in their research. But they turned him away because they had these explicit instructions to not give any of these agents to undergrads. But as time passed, they began to defy the rules, and they did indeed start giving these psychedelics out to undergraduate students as well. He found out about this. He was angry because he was turned away when he wanted to join the experiments, and he sought revenge by writing an expose of them and their research in the school paper, the Harvard Crimson. So his article led to an investigation, and they were then disciplined for giving psychedelics to undergrads and also for lack of scientific rigor in their experiments. Eventually they were fired. And then Timothy Leary went on to become an activist and a leader of the anti-establishment movement, as well as the anti-war movement. And he's famous for telling young people to turn on, tune in, and drop out. Richard Alpert went to India and studied under Guru Neem Karoli Baba. He changed his name to Ram Dass and came back to the States, where he was a spiritual teacher and was especially known for his Be Here Now books and lectures. So, of course, psychedelics have influenced our culture in many, many ways, too many ways to say, but certainly through music, film, and literature. We see the influence that is very prevalent. So in the mid to late 60s, public sentiment has really begun turning against psychedelics. Psychedelic drugs like LSD have now become inextricably linked with the anti-war movement and with the anti-establishment movements. And this is credited in large part to Timothy Leary. A lot of people were kind of mad at him about that. Nixon and his war on drugs also helped to demonize these psychedelic agents. And under the Nixon administration, the Controlled Substances Act was passed, and all psychedelic agents were classified as Schedule 1, which basically means no medical value and high abuse potential. By 1974, all psychedelic research in the US was shut down. So we'll shift now to look a little bit at some pharmacology. So the molecule on the left there is psilocybin. So psilocybin is a tryptamine found in several mushroom species. When it's ingested, it enters into first-pass metabolism, where it's changed into psilocin by the liver. Psilocin freely crosses the blood-brain barrier and is really the active form of the drug. So when you read papers about psilocybin in the brain, they're basically talking about psilocin. The elimination half-life of psilocybin is 3 hours. And then I also included on the right there just a picture of some dried psilocybin mushrooms, and just note the blue bruising, which is felt to be indicative of the level of the amount of psilocybin that is in the mushrooms. So here I wanted to show, if you look at the two molecular pictures on the right there, the similarity between psilocin and serotonin. And they're really almost identical chemical structures, with the only exception is the location of the hydroxyl group. So it turns out that psilocin binds strongly to many of the serotonin receptors, including the serotonin receptor 5-HT2A, and agonism by psilocin at the 5-HT2A receptor is felt to be the cause of the psychedelic effects. So psilocin also has activity at non-serotonin receptors in the brain, and the research here is still pretty new, but it's felt that most likely there are other receptors being affected by the psilocin, which contribute to its psychological and physical effects. So among these things that they've found so far, psilocin deactivates SERT, which is a serotonin transporter, which leads to higher serotonin levels in the synaptic cleft and allows for additional firing of postsynaptic neurons. Psilocin also activates the dopamine D3 receptor, thereby inhibiting dopamine reuptake and breakdown. And this is the means by which psilocin may have some effects on motor function and cognition. At the serotonin 5-HT2C receptor, psilocin seems to have an agonist and antagonist effect, kind of a mixed effect there. And this appears to have anxiolytic and antidepressant effects on rats. But one point I think it's important for us to know is that psilocin does not act at the dopamine D2 receptor. So we know that, of course, the D2 receptor is often a target for us with our antipsychotic medications. But this would explain why, if someone is intoxicated with psilocybin, giving them a typical antipsychotic will not reverse the effect of the psilocybin. Moving on to some effects now. So of course, this varies greatly between people, but these are just some of the commonly reported effects. So at a low dose, psilocybin is often reported to cause a slight drowsiness. People report that maybe any kind of pre-existing mood state may be somewhat intensified. At a medium dose, people often report a feeling of, like a mild feeling of euphoria. And at this medium dose, people often report with their eyes closed, they're able to see these very colorful geometric patterns. They may have some enhancement of their affect. They might find that they have an enhanced ability for introspection. People report that at this dose, they may feel that they're in a dream state. They may report perceptual changes like illusions, synesthesia, or changes in time perception. At high to very high doses, often people report visions of beauty, often indescribable beauty. Often, again, usually seen with the eyes closed, so it's not really a classic hallucinogen in the sense that we might think of it. Often people report a sense of oneness with others or with the universe. They may report a feeling of having like a revelation about love being all important. And this is basically what is part of what we call the mystical experience, which we'll talk about in more detail a little bit later. Now, also, it's important to know that at these high doses, these high doses can induce essentially dissolution of the ego. So this can manifest in people or present in people as very vivid, frightening experiences of danger or death, which could easily then result in panic. So it's very important in all of the research studies that I will be talking about here soon. Patients need to be, or participants really need to be properly psychologically prepared for that. All the research papers, all the research studies that I've read, the psilocybin and other psychedelic agents are contraindicated in people with a history of psychosis or an underlying psychotic disorder, because it has been seen that in people with an underlying psychotic disorder, psilocybin can precipitate an episode of psychosis. So common physical side effects include mydriasis, which is dilated pupils, increase in blood pressure, and usually transient nausea or headache. So they've looked at other serotonin 5-HT2A agonists in animal studies. And some evidence has been coming in on these. So there's other agonists besides psilocybin. But these agonists seem to enhance cognitive flexibility. They seem to increase associative learning. They seem to increase neuroplasticity, possibly via brain-derived neurotrophic growth factor. And there is evidence of antidepressant responses in these animal studies. Moving on to safety concerns. So tolerance with frequent use does occur with psilocybin. However, psilocybin does not cause physical dependence, nor does it increase the risk of abuse or dependence on other drugs. Psilocybin has a very low toxicity. It has a safety ratio of 1,000, and a safety ratio is defined as the therapeutic dose divided by the lethal dose. So just as a comparison here, fluoxetine and caffeine both have safety ratios of 100. So fluoxetine and caffeine are 10 times more toxic than psilocybin. Alcohol has a safety ratio of 10. So that means it's 100 times more toxic than psilocybin. And when they extrapolated the LD50 from rats, and the LD50, of course, is the dose at which 50% of people would die. The LD50 dose would be, you would have to get to the LD50 dose, you would have to consume 3.7 pounds of dried psilocybin mushrooms. So most research protocols use between 12 and 30 milligram doses of psilocybin, which is equivalent to approximately 1.2 to 3 grams of dried mushrooms. So this graph is just compares the safety of several different drugs of abuse, where the y-axis is the dependence potential, and on the x-axis, it's essentially lethality. So you can see here, the bottom left, LSD and psilocybin have a very low dependence potential and also a very low lethal dose. So in comparison, you could see heroin up at the right-hand upper corner that has both very high dependence potential and very high lethality. So now we're going to move into the research, but before we get to the research in detail, I really want to emphasize this notion of set and setting. So these are considered to be very critical components in contemporary psychedelic research. By set, that really means mindset. So this is really the psychological preparation that research participants go through. And they undergo several sessions with a psychotherapist or a therapist who has special training in working with people who are in non-ordinary states of consciousness. So these sessions occur in the days or weeks prior to the day of the medication dose. So the purpose of these sessions, the purpose of this preparation is to facilitate trust, to cultivate a sense of openness and of letting go to resistance, and also to alleviate any anxiety in the participant. Now, most studies involve only 1 or 2 doses of psilocybin, and they are always given in a comfortable living room-like setting that is actually a medical setting. So the picture on the left is from Johns Hopkins, and this is this is just a typical setup of one of their medication rooms where they administer psilocybin in their psilocybin-assisted psychotherapy studies. The protocols pretty much across the board always call for 2 therapists in the room with the participant at all times. Vital signs are checked regularly, and there's always a physician on call nearby. In most of the research protocols, participants listen to the same soundtrack, and most of them wear eye shades. And then after the medication session, it's also emphasized in these research protocols that there are usually several sessions of like integration sessions, so that the therapists meet with the participant to help them process the experience and to perhaps glean some psychological insights from their experience with the psychedelic drug. So the first studies we're going to look at are psilocybin with end-of-life anxiety and depression. So most of these are studies with people who have terminal cancer. So one of the first studies to come out after the whole moratorium on psychedelic research was this small pilot study from UCLA. This was a group of 12 participants, all with terminal cancer. They were all administered 1 dose of psilocybin. Now this was considered a low to moderate dose, 1.4 milligrams, and they used a niacin in their control group. All of these studies are crossover. And I know I'd heard a lecture from Dr. Grob in my program at at CIIS, where he said he really, really wanted to use a higher dose of psilocybin, but it was all so new, he could not get approval for a dose higher than 14 milligrams. So the participants were screened, of course, all received psychological preparation and support. And just briefly, a summary of their results. Their state trait anxiety scores dropped significantly at 1 and 3 months post-dose. And their BDI scores dropped almost 30% at 1 month after the dose. But this was not quite statistically significant. But when they tracked these participants 6 months out, the difference became significant then. There were no serious adverse effects, only mild transient heart rate and blood pressure increases. So next, in 2016, a few more studies came out. This was from Johns Hopkins. So this was this one used a higher dose. They used either a 22 or 30 milligram dose. For their control, they used a low dose of psilocybin. These were participants who were suffering from terminal cancer, depression, and anxiety. Their primary outcome measures were the HAM-A, the HAM-D. And I'm just going to, since it's the same in every study, I'm going to stop saying it, but they all did engage in psychological preparation, support, and integration after the medication session. Again, crossover design. So the results you see in these graphs are the first 2 bars in each pictogram are before the crossover. So half received the low or placebo dose first, and then half received the high dose first. There was 5 weeks in between. And as you can see, there were large and sustaining effects seen in both of their primary outcome measures. And without getting too detailed into it, the overall rates of response on depression and anxiety were 78 and 83% respectively at 6 months. So again, this was after 1 dose of psilocybin in a medical setting. This came out of NYU. It was also a higher dose study with psilocybin. They used niacin as their control. All of these participants had cancer and diagnoses of anxiety and or depression. All, and if you can just kind of like eyeball the graphs here, if you don't mind. The turquoise, the blue color is the placebo or the niacin, and the purple is the psilocybin. So compared to placebo, the placebo first group, and this is all pre-crossover, what we're seeing here. So the psilocybin first group showed significant reductions pretty much at every time point in all of their primary outcome measures. These results remained significant. You can see it up to 7 weeks in these graphs, but they followed them for they followed some of the participants for 8 months, and they also essentially maintained that difference, or at least they didn't maintain their difference because they all by then had both doses. They maintained their improvement in these outcome measures. So the effect sizes were pretty good, between 0.8 and 1.69. Okay. So this is a small study looking at psilocybin for treatment-resistant depression. This came out of the London Imperial College, was published in Lancet. This was an open trial, but I'm including this because they did a 6-month, they tracked these folks for 6 months, and that I found that those results to be pretty compelling. So each participant here received 2 doses of psilocybin, a 10 milligram and a 25 milligram, 1 week apart. Their primary outcome measure was the QID scale. They found that the psilocybin doses were well tolerated. Their adverse effects were transient confusion, anxiety, headache, nausea, and compared to baseline, their depressive symptoms were markedly reduced. But what I really want to show here is how they tracked them for 6 months. So they added 8 more people to the original 12, so they had a total of 20 people. And again, everybody received the 2 doses of psilocybin. And you can see here, so these are on this, these are their QID scores from baseline to each of these different time points. And in the red are the effect sizes. And they also reported that by the beginning of week 1, there were significant improvements in their suicidal ideation. So yes, I don't know any antidepressant that you give 2 doses of, and then 6 months later, there's a certain number of people are still doing really well. Okay, this one is also major depression disorder with psilocybin, but not treatment resistant. So in here they used, they also did a delayed group and an immediate treatment group. They also got 2 doses of psilocybin. The first dose was 20 milligrams, followed by a 30 milligram dose between 1 and 2 weeks later. And the results, again, the antidepressant effect of the 2 doses of psilocybin was robust, and it sustained for 8 weeks. And just to give one little detail of the results, 4 weeks after the second dose, the response rate was 71%, and the remission rate was 54%. And the little graph there just compares the delayed treatment group to the immediate treatment group. And of course, the delayed treatment group was still getting the psychotherapy, the psychological support, the same as the group that got the psilocybin. So these are very high Co-and-D effect sizes there in the 3s. Now this study just came out last week. So it's also another blinded randomized controlled trial with moderate to severe major depression, and it's comparing psilocybin to escitalopram. The trial lasted for 6 weeks. So in this study, in the escitalopram group, they did receive 1 milligram, so these are very, very low doses of psilocybin 3 weeks apart. And they also received 10 milligrams of escitalopram every day. The psilocybin group received 2 25 milligram doses of psilocybin 3 weeks apart, and they received a daily placebo. This trial is especially interesting because they also did functional MRIs and cognitive testing pre and post psilocybin dosing. These results are still pending. So the response rate for psilocybin was 70%. The response rate for escitalopram was 48%. The remission rate for psilocybin was 57%. The remission rate for escitalopram was 28%. And the change in the QID scale, while psilocybin showed slightly better improvement in depression compared to escitalopram, the difference was not statistically significant. And they did not have any serious adverse effects. Okay, so moving on to psilocybin and alcohol use disorder. So this is a small pilot study published in 2015 by our former faculty member, Michael Loganschutz, who was, after doing the study, was snatched away by NYU. So he had, in this study, he had found 10 people with alcohol dependence who were not currently in treatment. And it was open label. And they did receive a high dose of psilocybin. But the design of this study was very clever in that before anybody got any psilocybin, everybody got 4 weeks of psychosocial therapy and treatment. So everybody got 4 weeks of psychosocial therapy, then they got the first dose of psilocybin. Then they had 4 more weeks, excuse me, of psychosocial therapy, and then they got their second dose of psilocybin. So what they found was they found large reductions in their percent drinking days and percent heavy drinking days. And when they looked at their abstinence rates, they found that there were significant improvements in abstinence after the psilocybin doses, which were not present during the psychosocial treatments. So it really seemed that the psilocybin helped to improve abstinence rates much more than the psychosocial treatments. They also found some improvements in a variety of other psychological measures. These gains were largely maintained at 36 weeks. And the other point that the authors wrote in their paper was that they found that the reduction in drinking strongly correlated with the quality of the mystical experience reported by the participants. And I highlighted that just because I want to make sure we're going to be talking about that more soon. Now this, I need to give a big shout out to Dr. Bott. And so Dr. Bott, thank you if you're here. He shared a few of his slides with me. Dr. Bott has been collaborating with Dr. Bogenschutz at NYU and doing this phase 2 study with psilocybin-assisted therapy for alcohol use disorder. I've seen Dr. Bott shared with me a couple of the slides, and those early results are very interesting and compelling. So I would like to just ask you all to stay tuned for these results, and I do hope that Dr. Bott can have the opportunity to come talk about all of the results when they're ready. But this is a group of 100 people with alcohol use disorder, and they're using a rather high doses of psilocybin, 25 to 40 milligram. They're using diphenhydramine as a control. They're also doing neuroimaging. So that's going to be really interesting. This is another slide that Dr. Bott shared with me, and just to give you kind of a preview of what their study design is. It's a very beautifully designed study with high dose psilocybin. It looks like these participants are getting 3 doses of psilocybin. It extends over a year, and they're going to be looking at cravings, drinks per day, and as well as scores on the mystical experiences questionnaire. And the other little bit of information I want to share here is that UNM is going to be one of the phase 3 study sites with Dr. Bogenschutz as the PI as they move into the phase 2 is now winding down, and the results are being analyzed. So the phase 3 study should hopefully start maybe by the end of this year or early next year. So that's going to be very interesting. Okay, so I did want to talk to you guys a little bit about the mystical experience. So I think that for people who are trained to be scientists, the concept of the mystical experience might feel unscientific, because it might suggest to us some involvement of spirituality or the supernatural, and which really might feel like it's antithetical to the scientific method. But I have studied this a lot with, I've gone to many lectures from many psychedelic researchers and read lots of their papers. They generally want to be very clear that they are referring only to the phenomenology of this experience, that they do not endorse any supernatural or metaphysical ideas. And it's very clear when you look at all of the studies that have been done, from the early studies in the 60s and 70s to contemporary psychedelic research, that profound psychospiritual experiences consistently seem to correlate with better therapeutic outcomes. So most of the contemporary psychedelic research uses one or both of these scales. One is called the Mystical Experience Questionnaire, and the other one is called the Altered States of Consciousness Scale. So I'm going to talk a little bit about the mystical experience questionnaire. I think this is the one that's most often used, and it has 6 components. The first, so these are components of the experiences that participants describe after engaging in these studies. So the first component is unity. So this is defined in the questionnaire as an experience of the insight that all is one, or that the fusion of one's personal self into a larger whole. It also includes the awareness of the living presence of all things. The next component is noetic quality. So this means a sense of certainty that one has experienced an ultimate reality, that it feels like this is really real. The next component is sacredness, that this is the feeling that one has experienced something profoundly divine or maybe even holy. The next component is transcendence. This is the sense of being outside of time, beyond past and future, being in a realm with no space boundaries. And what I found very interesting was in reading some of the quotes from some of the participants in the cancer studies, one of the themes that came across was that it felt to many of them that it was a profound gift to have the psychedelic experience because it enabled them to no longer feel stuck having to identify with a diseased body. Made them feel that this was not them. The next component is a deeply felt positive mood. This can include feelings of awe, amazement, joy, peace, tranquility, tenderness, and gentleness. And then the final component is ineffability, which is a feeling that words cannot describe the experience or do justice to the experience that one has during the psychedelic treatment. Now, the altered states of consciousness scale. I'm not going to go into all of the components of this, just to talk about one of the components, which is called the oceanic boundlessness component, which includes insightfulness, blissfulness, an experience of unity and spirituality. So the Carhart-Harris group, which is the group from the Imperial College of London, although now Robin Carhart-Harris has been recruited to UCSF to run their psychedelic program, but their group found that the higher the oceanic boundlessness score was in the scale, the more predictive of a reduction in depressive symptoms they found. And this occurred more so than the perceptual effects. But regardless of the term that we use to describe these experiences, again, profound psychological experiences during psychedelic therapy have been shown to predict therapeutic outcomes so far. So this tends to beg the question, and in my discussions with colleagues, this question often comes up. Is the psychedelic experience, otherwise known as a mystical experience, necessary in order to achieve a therapeutic response? Of course, I'm not qualified to answer this, and I don't think we can definitively answer this question yet. But I suspect that many researchers in this field might say the answer is yes, or probably yes, just from my interactions with them. And here's where I just want to introduce this concept, which was new to me, but this concept of experiential medicine. So this is the idea that, which is so different, I think, than the way we're trained as psychiatrists. But this means, so experiential medicine means that it is not the molecule per se, which is actually going into the brain and then treating the illness, but that the molecule induces an experience. And it's the experience which is the therapeutic element, which I understand this might likely be controversial. Okay. So sorry, in the next few minutes, I just want to briefly touch upon MDMA. And the reason I want to talk about MDMA is because MDMA is currently in phase 3 trials for treatment-resistant PTSD. And it's being fast-tracked because it has FDA breakthrough status designation. So the thinking is that it's very likely to be approved for treatment-resistant PTSD by the end of 2022, maybe 2023. So MDMA is a derivative of amphetamine. Structurally, it's related to mescaline. It was developed in Germany in 1912. It was used by a few psychiatrists along with psychotherapy in the 1970s. In the 1980s, ecstasy, which was purported to contain MDMA and probably did to some degree, perhaps along with other contaminants, but ecstasy was used in ways that could cause adverse effects and did cause harm to people. Thus, in 1985, MDMA was classified as a Schedule I drug. There are neurotoxicity concerns with MDMA, but so far, some neuroimaging studies did not show any evidence for changes in brain structure, changes in serotonin receptor density, or in cerebral blood flow at the doses that are used in current research. But it has been seen that in people who use MDMA heavily and frequently, this does lead or can lead to reduced density of serotonin receptors. So MDMA increases the release of serotonin, norepinephrine, and dopamine. It also activates muscarinic, adrenergic, and histaminergic receptors. MDMA also increases the release of a number of hormones. So these are likely to be contributors to its psychological effects, especially oxytocin. And here's the graph with the drugs of abuse again. And you can see you have the red arrow pointing to MDMA. So it's clearly, definitely higher up on the lethality scale. And it's felt to be at low or moderate dependence potential. So why was MDMA chosen to be combined with psychotherapy for PTSD? And I think this is some of the thinking in designing this research. So MDMA appears to enhance feelings of empathy, connectedness to others, compassion, both for oneself and for others. It seems to increase self-acceptance, reduce fear and defensiveness, increase interpersonal trust, and increase the ability to gain insights. It can therefore enhance access to painful memories. It seems to modulate the level of arousal during the psychotherapy itself. It can strengthen the therapeutic alliance. It facilitates processing. And it seems to allow for reconsolidation of memories so that they can be disassociated from the high arousal state in which they were initially planted into the brain with. Just a little bit about the phase 2 designs for MDMA. So the participants in the phase 2 MDMA trials all had chronic PTSD. They had a diagnosis of PTSD on average for 17 years, and they had failed previous treatments. They enrolled people who had gotten their PTSD from a variety of causes, both civilians and veterans. They were randomized to a control group, which was very low dose MDMA, or to a high dose MDMA. And here I have to apologize to the residents who I gave a lecture to recently, where I misspoke and said the dose was 300 milligrams, but in fact, I went back to check and it was 125 milligrams. And there was an optional half dose that people could take like 2 hours into the session if they wanted it. So the research protocols called for 2 or 3 medication sessions. These lasted 6 to 8 hours each. They were 3 to 5 weeks apart. And of course, the psychological preparation And with MDMA, it's opposed to psilocybin, but with MDMA, the participant can engage very actively in in therapy during the session itself. So they're not so zoned out that they can't participate in therapy. So they have active therapy going on during their medication session. Let's see. So pooled results, just a few little highlights here. An N of 105, and they used CAP scores as their primary outcome measure. In the active group with the high dose MDMA, their CAP scores dropped by 30.4 points. In the control group, the CAP scores dropped by 10.5 group points. In the active group, by the end of the trials, 54% no longer met criteria for PTSD. And in the control group, 22.6% no longer met criteria for PTSD. So all that therapy was probably beneficial, even though they didn't get the high dose MDMA. So the between group effect size was 0.8. And then when you looked at the pre and post effect sizes in the groups, some of the groups, there was an optional third session. So if you look at the people that got the two sessions with MDMA, the pre-post effect size was 1.4. In the group that got 3 dosing sessions, the pre-post effect size was 1.9. And then this is a quote from Rachel Yehuda, who's a world-renowned PTSD researcher and director of the Traumatic Stress Studies Division in the Icahn School of Medicine. She says, MDMA-assisted psychotherapy has demonstrated greater therapeutic efficacy than any other psychotherapy or medication for PTSD. This is just to show that psychedelic-assisted psychotherapy is being researched in a number of other disorders and is showing signs of benefit in several of these. And this is not an all-inclusive list at all, but there is evidence of some benefit potentially in OCD, tobacco dependence, in pain, and as an anti-inflammatory agent. And then that's pretty much it. This is my last slide. This is just a bunch of different organizations that are either involved in psychedelic research or in the funding of psychedelic research. And that is all I was going to talk about. So now, if anybody has questions, please feel free. Let's see here. I don't know if people are putting any questions in the chat, or if somebody wants to read me questions.
I have a question, Denise. Thank you. This was a great presentation, very thorough and balanced, and I appreciated it. And I think the results from the randomized controlled trials are very encouraging. My question goes to the relationship between the mystical experience and efficacy. And you said that there's an idea that maybe it's not the pharmacologic effect necessarily, but it's the mystical experience what leads to the efficacy. And I am aware that in the 70s, there was a lot of research with sensory deprivation tanks, like floating sensory deprivation interventions, like tanks where people would float in warm water for hours to elicit sensory deprivation. And my question is, have you looked into that literature to see whether a non-pharmacological, perhaps mystical type of experience could result with similar beneficial effects?
That's a really nice, really good question. Thank you for saying that, for asking. I have not looked into any literature on sensory deprivation and efficacy for mood disorders. There is a little bit of literature, not much, but a little bit using holotropic breath work, which was actually it's a type of breathing exercise that was actually developed by Stan Grof after the psychedelic research was all shut down. It's essentially a way of hyperventilating to the point that you have a very weird sort of almost like a psychedelic experience, and it's in conjunction with like very activating dramatic music. And there is some benefit. There is small, at least case studies, but a small amount of literature that seems to support some improvement in mood and anxiety in people who have gone through this holotropic breathwork experience. But I think that the answer is really unknown. And it's a debate currently right now underway in the ketamine, among ketamine practitioners. Because there's people who advocate for ketamine infusions in which people are just completely zoned out. They don't know what's going on. They're certainly not having a spiritual experience because they're so zoned out, they're so sedated, but yet they have maybe in some of these studies very significant improvements in their depression, and there's no therapy around that. So that is a debate. I think that the question has yet to be answered, but it certainly is an interesting notion, and I know pharmaceutical companies are probably really interested in that. As I've heard, they are working on designing 5-HT2A agonists as antidepressants that hope that in their mind don't cause a psychedelic experience.
Dr. Lin, thank you. That was excellent. I really liked your sharing with us the database that you've learned about. Since you mentioned ketamine, why, to my knowledge, which is limited, they don't do the assisted psychotherapy as part of the ketamine infusions, and why not?
Yeah, really, really great question. So yeah, there's several different camps in the ketamine world right now. There are those who advocate for IV ketamine, no therapy, and are finding some definite benefits for people with depression. Then there's actually a growing movement of ketamine-assisted psychotherapy advocates. You see this more on the West Coast or on the East Coast in the major cities now. It hasn't really come here to New Mexico, but they will utilize lower doses of ketamine so people are not as zoned out, and in fact can maybe in some cases engage in psychotherapy. And there's not much research with the ketamine-assisted psychotherapy, but I think the reason is because ketamine was already an FDA-approved drug, so it was people right away started using it off-label in a similar way that they might use for anesthesia, except at much lower doses. So I think that's why they just haven't done the research, because they had access to the drug already. But I've spoken to many people who are ketamine-assisted psychotherapy proponents and practitioners, and they swear up and down that low doses of ketamine given sublingually or by IM means can induce very dramatic improvements in mood and anxiety and various disorders. And this is just anecdotal because they haven't researched it.
Thank you. That's fascinating. You mentioned that terrible feeling, as I'll call it, that some people get with a psilocybin, or a feeling of danger.
Mhm.
Are they looking at ways to mitigate that in addition to the therapeutic surroundings, such like a pharmacological strategy to mitigate those bad effects?
Yeah, there's always, all of these research protocols, they always have the option of giving a rescue medicine. And usually they'll use benzodiazepines if someone is really freaking out. But the thinking among like my teachers at CIIS is that those scary experiences when one is like face to face with, you know, with death in the, you know, that those are, if they have the right preparation ahead of time, then when they're in that experience under the influence of the psychedelic agent, that if they can accept it and move forward, that's where you can gain like these great insights. So they really try to counsel folks ahead of time to be really prepared for that. And then if it happens, to really to try to embrace it and accept it. So that's kind of the thinking in the teaching of psychedelic assisted psychotherapy. But certainly you could, you know, people could get a rescue dose of an anxiolytic if it was really bothersome, scary for them.
Denise, can I ask a question?
Sure.
First of all, I want to thank you for really, again, very elegant presentation and summary of what I think what is coming up with all of this new research is we suddenly opened the door on a, you know, on a room that's been locked for 60 years, and it's essentially exploding out into the field. And I think one of the real issues that's coming forward, and I think we've seen it in the questions, is what kind of methodology are we going to have to develop to be really able to assess what aspects of this treatment, which is very complicated, is going to contribute to the overall treatment response. So we know there's a drug effect, and we know there's this correlation with this mystical effect. But the ultimate question is, what's going to be the mechanism for that? You know, and how do we tease that out? Because as we kind of see with some of the studies, and I think the citalopram study is very interesting, when you just gave when you gave the SSRI compared to the psychedelic drug, they didn't differentiate very much. But that study really didn't focus on the difference in what was the psychotherapeutic component. So I think when we're going to be talking about these drugs and effect sizes, we're not just talking about an effect size, a specific effect of the drug. We're going to be talking about this combination of what does the psychotherapy aspect of it, how much does that contribute to the treatment, and how essential is that going to be? And what are your thoughts on that?
Yes, no, I agree. I think that's a very astute comment. And I was there's a researcher, his name is Adam Gazzaley, and he runs the Neurosciences Center at UCSF. He's an MD, PhD, big researcher guy. He actually develops video games that have neuropsychiatric effects. And he has spoken on that very topic. He says that with psychedelic research, where we are now is we have some, we have a little bit of like very basic science kind of lab work. And then we have some of these clinical studies with some kind of end results and efficacy studies. But there's this vast area in between that has not yet even been looked at all. Like everything you said, like what constitutes the therapy, of what are the elements of the therapy that are really the necessary elements? What is going on in that therapy? What is the preparation that needs to occur? There's so many questions in that broad middle area that still have yet to be answered. I think you hit the nail on the head with that comment. But yeah, I certainly don't have a good answer for you on that. I just think we're just at the very early stages of this research.